Bismillah ar-Rahman ar-Rahim. My pleasure to meet again in Prince Fatma Academy now we're going to present the Ministry of Health guidelines for COVID-19 infected patients with renal problems. We'll start with those who are on hemodialysis and suspected or confirmed to have COVID-19 infection. Well, first of all, these guidelines are established by the Ministry of Health, the Crisis Management Committee in the Ministry of Health, in order to reach a general consensus about how to deal with patients in some comorbidities, special population patients like those with kidney problems, heart problems, liver problems, and so forth. I have the pleasure and honor to be invited by the Ministry of Health to represent the nephrology population, and I was assigned to form this committee of nephrologists. I had two other colleagues. We started to work on this and we presented this work. We hope that it will be of benefit, inshallah. Well, as you see, we formed an algorithm for what we are going to talk about, but we put it in an algorithm form to make it easier for each one to grasp the idea and to deal with in a very swift way. The management protocol for dialysis patients suspected to have COVID-19 infection, first of all, you have to have a form of triage. This triage might be whether in the hospital or at home, in the hospital or the dialysis center or at home. That means that the patient may call the center and inform his physician before even reaching the center about his condition, about the constitutional symptoms that you are going to talk about, and the physician may start his triaging while the patient is still at home. So whether at home or in triage, let's say when the patient arrives to the facility, as in the reception or front desk of the facility, whatever, if the patient confirmed that he is complaining of fever, cough, dyspnea, sore throat, or influenza-like illness, fever, it's variable. Some said it's 38, some said 37.3, some set a point of 37.8. Anyways, a fever or complaining of high body temperature, cough, dyspnea, sore throat, or influenza-like symptoms should be reported. In contact, or if the patient was in contact with COVID-19 infected people, or within 14 days prior to the onset of the disease. Okay, history of travel within 14 days. If the patient said that he was in a place known for high prevalence of COVID-19, let's say a patient coming from Italy or Wuhan in China or some other places in the world where there is a high infection rate, so it should be also kept in mind that this patient might be a potential carrier. Or in contact with patients who have fever or respiratory symptoms. If the patient said that they have a brother, a son, or whatever, who developed fever or respiratory symptoms, but he does not yet confirm to have an infection, then you should be suspicious also about this patient. First of all, this patient, when he arrives complaining of such symptoms or having one of these above mentioned criteria, two of them will be very conclusive. If the patient is suspicious, first of all, proceed for kidney function test ABG, and clinical assessment of the patient. If he was not indicated for urgent dialysis, postpone dialysis until results are obtained of the investigations to confirm or to disconfirm that the patient is infected. So, first of all, when the patient is complaining, we will take the necessary investigations to sort out whether this patient is in need for desperately needing dialysis, urgently needing dialysis, or the patient is not that urgent. So if he's not, then we will continue with the investigations, but we will not proceed for dialysis till we get the results of the investigations after maybe a few hours or the second day. But if the patient have a mandatory cause that necessitates immediate dialysis, like if the patient has hyperkalemia, severe hyperkalemia, or intractable acidosis, or any other, or pulmonary edema, let's say, or impending pulmonary edema, any other cause that will necessitate urgent dialysis, then we will do dialysis, as we will show you later, but in a separate context. So we will triage the patient, do the necessary investigations to know how urgent he is regarding dialysis, and then we will go, if the patient showed these one of the above mentioned 4 criteria, we will proceed to high resolution CT chest and chest consultation. If the patient is coming complaining of one of the above mentioned criteria, then we will do high resolution CT chest and chest consultation. In some areas where CT was not readily available, you can shift to chest X-ray and pulmonary medicine consultation or chest consultation, but still it's not that accurate like the high resolution CT. So high resolution CT is the gold standard, plus the chest consultation. You will have one of 3 possibilities. If the patient chest X-ray and CT was shown to be normal, then you will proceed to routine dialysis. Maybe the patient has fever from a catheter or whatever, so it's not related to the chest condition. But if the patient showed CT appearance non-suggestive of COVID-19, or what we can say non-suggestive of viral pneumonia, then we will proceed to the laboratory tests that suggest of COVID-19, like CRP, CPC, D-dimer, ferritin, fibrinogen, triglycerides, liver enzymes, and others. If they were all negative, then we will do routine dialysis in isolation zone in the last shift, in a separate room if possible, or in isolated or secluded area inside the main ward in the last shift, as we said, with a designated nurse, alone with a designated nurse, and the nurse should be wearing the protection, the full protection, personal protection equipment, or at least the protection with the gloves and masks and face shields till we get the results. And then this will be carried out for 14 days. After 14 days, we will repeat CT chest. If the condition of the chest, the images that we have seen before has improved, then the patient will return back to routine dialysis, as far as there is no other development or symptoms of new symptoms or worsening of the condition. So, but if the condition is worsening, or the CT appearance from the beginning was suggestive of COVID-19, then we will go to nasopharyngeal swab for PCR or nucleic acid testing. If it was negative, which is the first sample, or waiting for results of the first sample, so if the first sample was negative, or while we are awaiting for the sample, we can go for routine dialysis again in isolation zone in the last shift, as we said, and then we will repeat nasopharyngeal swab for PCR after 48 hours. If it's again stayed negative, then the patient will stay in the last shift dialysis, as we said, for 14 days, repeat the CT. If the CT is improving, then he will go to normal dialysis ward again. If the nasopharyngeal swab, the second sample, became positive, then transfer to dialysis ward in COVID-19 designated hospitals. So these are the algorithm. One important thing we should say that nasopharyngeal swab will be also carried out if the laboratory tests for the CT appearance, which was not very suggestive of COVID, was also positive, were positive, so we go for nasopharyngeal swab. Or if the CT chest for the same patient who have CT appearance non-suggestive of COVID-19, and he became worse after 14 days of isolation, then we will go for nasopharyngeal swab nucleic acid testing. So this algorithm will help us to deal with this kind of patients. Now we'll talk about what we said in the algorithm. What we summarized in the algorithm, we will say it here in a more comprehensive way. So when you have a suspected case, as we said, take an electrolyte panel to see whether dialysis is immediately needed or that this can be postponed until the results of the nasopharyngeal swab and high-resolution CT of the chest are known. Early recognition and isolation of individuals with respiratory infection. Facilities should implement sick leave policies that are non-punitive, flexible, and consistent with public health policies that allow ill healthcare personnel to stay home. Healthcare personnel should be reminded to not report to work when they are ill. Facilities should identify patients with signs and symptoms of respiratory infection, example fever, cough, before they enter the treatment area. Instruct patients to call ahead to report fever or respiratory symptoms so the facility can be prepared for their arrival or triage them to more appropriate setting, example in acute care hospital, an acute care hospital. Patients should inform staff of fever or respiratory symptoms immediately upon arrival at the facility, example when they check in the registration desk, and patients with symptoms of a respiratory infection should put on a face mask at check-in and keep it on until they leave the facility. Facilities should provide patients and healthcare personnel with instructions about hand hygiene, respiratory hygiene, and cough etiquette. Instructions should include how to use face masks, how to use tissues to cover nose and mouth when coughing or sneezing, how to dispose of tissues and contaminated items in waste receptacles, and how and when to perform hand hygiene. Post signs at clinic entrances with instructions for patients with fever or symptoms of respiratory infection to alert staff so appropriate precautions can be implemented. Facilities should have supplies positioned close to dialysis chairs and nursing stations to ensure adherence to hand and respiratory hygiene and cough etiquette. These include tissues and no-touch receptacles for disposal of tissues and hand hygiene supplies, example alcohol-based hand sanitizers. Patient placement. Facilities should have space in waiting areas for ill patients to sit separated from other patients by at least 6 feet. Medically stable patients might opt to wait in their personal vehicle or outside the healthcare facility where they can be contacted by mobile phone when it's their turn to be seen. Patients with respiratory symptoms should be brought back to an appropriate treatment area as soon as possible in order to minimize time in waiting areas. Facilities should maintain at least 6 feet of separation between masked symptomatic patients and other patients during dialysis treatment. Ideally, symptomatic patients would be dialyzed in a separate room if available, with the door closed. If a separate room is not available, the masked patients should be treated at a corner or end of row station away from the main flow of traffic if available, and the patient should be separated by at least 6 feet from the nearest patients in all directions. Healthcare workers should be trained for dealing with all cases under PPE according to individual case scenario. This paragraph I want to make some explanation about. Well, first, as we said in the algorithm, whenever you have a chance or confirm that your patient have a COVID-19, then you should notify the authorities, and the patient should be transferred to COVID-19 infected patient. What I read now is how to deal with the patient before making sure that the patient is COVID-19 infected, and if the patient was infected was COVID-19 infected and it's confirmed, but the patient was in a desperate need for dialysis and he cannot be transferred anywhere else unless he take his session, so you can do that. Or if, God forbid, the number of patients increased and outweighs the facilities, so we by that time, if we could not designate certain hospitals for COVID-19 confirmed cases, and and it became widespread everywhere, so you would have to deal with these cases in their own facilities, their own usual facilities where they are used to do their hemodialysis there. So by that time, you should do it with these measures: PPE, personal protecting equipment, and last shift dialysis or a separate room dialysis with a designated nurse, and to be away from others at least 6 feet or 2 meters, and so forth. So the first important thing is, when you have if you still have the luxury of sending the patient to COVID-19 confirmed cases or designated hospitals to dialyze there and to be isolated there, this is the best scenario. If not, and this facility was not available, then you do it with such precautions. When COVID-19 is suspected or confirmed in a patient receiving hemodialysis at the facility, the following additional measures apply. The health department should be notified, as I said. Healthcare personnel should follow the interim infection prevention and control recommendations for patients with confirmed coronavirus disease or persons under investigations for COVID-19 in healthcare settings. This includes recommendations on PPE, routine cleaning and disinfection, appropriate disinfection for COVID-19 in dialysis settings. Any surface, supplies, or equipment, example dialysis machines, located within 6 feet of symptomatic patients should be disinfected or discarded as well. And then minimize patient exposure. Encourage patients and their caregiver, if needed, to use their own transport and to travel alone to dialysis until when possible. So if the patient coming to your to have his session, you encourage him to come with his own car or a private car if he has the luxury to do so. If not, and he has to travel or to come transportation by public transportation, then he should be taking care of wearing mask, wearing gloves, avoiding crowdness, avoiding not to sit beside someone who's showing any signs of influenza, and so forth. Minimize the time in the waiting area by careful scheduling. You should schedule your patients with no overlap between shifts. Try to make it there's some sort of time lag between the shift and the coming one. So you have at least 1 hour between shifts. So you will make sure that the first shift is totally evacuated and the patients departed the facility totally, and then the new patients come. So we will avoid the crowdness and to make sure that the patient will be immediately connected to his machine, not waiting. So we reduce the waiting time. And we should encourage patients not to arrive early. We can text patients when the facility is ready to receive them. If they can wait outside, let's say, in their cars, for example. If a patient is COVID-19 negative and has symptoms, we should ensure that other explanations for the symptoms have been considered and treated. At subsequent assessment, retest the patient if there is still a clinical suspicion of COVID-19, outlining restrictions to the dialysis unit to those staff and visitors essential to the delivery of the service. Keynotes: educate your patient how to stay safe at home. Educate patients, relatives, how to protect themselves from COVID-19. Encourage patients not to use public transportation if possible. If not, use all protection tools, example, face mask and gloves. Patients' entrance and exit should not be in groups leaving about 6 feet, 1.8 meter spacing in between. Meals are not allowed on session. Only allow controlled snack, example, small candy, to prevent hypoglycemia. Washing hands upon entry and before leaving the center. Patients never share their personal belongings. On praying, do not use carpets, only pray while seated. Pass route for entering hospital and dialysis unit should be aligned, so the pickup and drop-off should not be shared with other dialysis patients. Entering and exiting with other patients at the same time should be avoided, and the route, mode, and time of transport of dialysis personnel should be fixed. How should facilities monitor or restrict dialysis facility staff? The same screening performed for patients should be performed for facility staff. So we should take their temperature, measure the body temperature. We should try to see if the patient has any influenza-like symptoms. Try to see if the patient was in contact, or the we're talking about the healthcare provider. If any of them was in contact with a COVID-19 case within the last 14 days, etc. So the same screening will be carried out as we did for the patients. Then dialysis staff who have signs and symptoms of a respiratory infection should not report to work. Facilities should implement sick leave policies that are non-punitive, flexible, and consistent with public health policies that allow ill staff members to stay home. Any staff member that develops signs and symptoms of a respiratory infection should immediately stop work. If working, put on a face mask and self-isolated at home. Inform the facility administrator and collect information on individuals, equipment, and locations the person came in contact with, and contact and follow the local health department recommendations for next steps, example, testing locations for treatment. The medical waste from confirmed or suspected patients with COVID-19 infection should be considered as infectious medical wastes and disposed accordingly. The health department should be notified in instances of suspected or confirmed COVID-19 infection. All the family members living with dialysis patients must follow all the precautions and regulations given to patients to prevent person-to-person and within family transmission of the COVID-19, which include body temperature measurement, good personal hygiene, hand washing, and prompt reporting of potentially sick people. Dialysis patients who have a family member or caregiver subject to basic quarantine can have dialysis as usual in accordance during the 14 days period. Once the family members or caregiver of dialysis patients have been converted to a confirmed case, the patient's identity should be upgraded and treated in a designated area with check for a confirmatory test for COVID-19. Now we'll come to the hemodialysis prescriptions in regular hemodialysis patients. According to the Egyptian guidelines by the Egyptian Society of Nephrology and Transplantation, all patients should receive their regular hemodialysis sessions in both duration and frequency. So there is no change of duration and frequency of sessions during the COVID-19 era from the non-COVID-19 era. It is advisable to use the high flux dialysis membranes and always individualized therapy according to patient's needs. Hemodialysis modality. Cytokines storm associated with elevated levels of interleukin 6, 18, and interferon gamma are associated with more severe disease and higher mortality. Extracorporeal therapies using high volume hemofiltration or adsorption to decrease cytokine levels may theoretically be expected to confer benefits. Peritoneal dialysis, acute PD, use of acute peritoneal dialysis can be life-saving and should be used as and when required and in the setting where hemodialysis facility is not available. Healthcare workers should use all precautions while initiating acute PD and discard use consumable probably. So we will stop here and we will give in the next lecture the guidelines for AKI in COVID-19 infected patients, and the third lecture will be about guidelines for COVID-19 infected patients who have kidney transplantation. I hope for each and every one of you good health and Ramadan Kareem, and inshallah see you as soon as possible. Thank you so much.